Welcome to May I Interrupt, an eye care roundtable discussion show sponsored by OCULUS. Each show, we explore questions in the world of eye care and other topics of interest with leading experts in the industry. We do this in an irreverent, but hopefully funny manner. I'm Craig Norman, and I'm joined by my friend, colleague, the magnificent, witty, and yet to be a winner on this show, Dr. Jason Jedlicka from Indiana University College of Optometry. Jason is known throughout the world as an expert on contact lenses, topography, lens design, and his inability to win.
Correct.
Jason, not time to interrupt just yet.
Good morning, Craig.
Hi, buddy. How are you?
Okay.
Jason, are you ready to take on today's challengers?
Wow. Well, I'll take them on.
I think,
but
you know
how I'm going to fare. So,
yeah. I dreamt last night that you won.
Yeah, that's about the closest I'll get, probably.
Yes, might be. So we have two great guests. Dr. Crystal Brimer graduated with a Bachelor of Science in Biology at the University of North Carolina at Chapel Hill, Tar Heel, and earned her Doctor of Optometry from the Southern College of Optometry and is a Fellow of the American Academy of Optometry. Dr. Brimer's been in practice in Wilmington, North Carolina, I believe the home of Michael Jordan, if I'm not correct.
Absolutely.
Excellent. Craig gets a point. And for the past 20 years, has had a special focus on contact lenses and dry eyes. She's been involved in numerous clinical trials and is highly sought after as an author and a lecturer. And she's also the owner of Crystal Vision Services, an ophthalmic equipment company and practice management company. Dr. John Schachet is our other guest. It's really great to see John's face. He's been involved in the eye care industry for about as long as I have, so let's say more than 40 years, since opening his practice in Sentinel, Colorado. He served as a clinical investigator for numerous studies on contact lenses, corneal refractive therapy, dry eye treatments, and more. He's also a widely sought after lecturer, and he has the ability to bring insight both from a clinical end and from a technical end. If you've been paying attention over that last few decades, you've seen or heard John or read about him as he's been contributing editor to really all of the magazines that make sense for us in the eye care field. So here's our format. I'm going to ask questions and we will get responses from each of you. Approximately, it's going to take a couple of minutes, 2 to 3 minutes for each of these questions. And if you provide something interesting, again, you'll get points. And other than that, we really have no rules except for the may I interrupt part of it. And you'll learn how that works because Jason's personality will make that happen early. He'll be rude, he'll interrupt. And then
right, I interrupt a lot. So
see, right there.
Especially Craig.
Right there.
I mean, I might not interrupt you guys, but I will definitely interrupt Craig. So.
Yeah. So we keep points here. And the idea is to
Craig,
get a lot of points.
Can I interrupt?
Okay, how about this? You look good today, Craig. Is that what you're going to say? Okay.
I was thinking about saying that, but the reality is when you're like drawing this parallel between you and John, I was thinking, he doesn't look like he's been in practice nearly as long as you. So, John,
start with the minus, Jason.
Exactly. Well,
I see. This is the time because I'm at 0. I can't go any further down.
Yeah.
Oh, good. The rules.
So, Crystal, you've picked up on it. They're called demerits here, and he is the leading demerit scorer throughout the episodes that we've had so far. He's never really started out negative like this, but I guess
first time.
I think when John Gellis was on, John got a lot of demerits too. So.
I see. You're not man enough to take just that on your own. You got to blame it on somebody that's not here.
Yep, exactly.
Okay.
As long as you're good at something.
Exactly. Exactly.
We haven't figured out what that is yet, though. But
let's get started. Our first question, and we traditionally start with Jason. Hope he can get a couple points on the board before he loses.
It's my head start.
So there's a lot of noise, a lot of interest in dry eye today. And what I'd like to have you guys do, each of you in the time that you get allowed, is to convince the audience and me why the eye care practitioner should really embrace this as part of their practice today. Jason, what do you think?
I get to start? All right. Well, I mean, I think that everybody's looking for a way to differentiate, and everybody's looking to get less dependent upon, third party and whatnot. And I think this is something you can build a specialty around, and it's obviously a great service for patients. And I don't know, I feel like it's something that fits optometry really well. The treatments for it are, non-invasive and for the most part, and the equipment is something that integrates already with optometric equipment. And so I feel like from that perspective, it blends naturally. It's something that a private practitioner is going to have the patient base already in their practice to develop. It's not something they have to go find patients or recruit patients or market to certain patients necessarily, although they can. I just think it's a natural place for people to start to build something in their practice that is interesting to them and enhances their practice personally and professionally.
Excellent.
So
Crystal
am I
Brimer,
back to zero now?
you are. You're at
Okay.
0. You're even for the day.
Perfect.
I'd
Crystal?
sum it up in, get on board or get left behind. Because if you're not doing it, they're going somewhere else. Now, that doesn't mean that everybody's doing it well. And when you embrace it and you go a little deeper, then you get the outcomes, which gives you the revenue, but more importantly, the fulfillment. I have so much fun. Can I keep going though? Is that okay? Okay. I have so much fun with dry eye, and I think it's because I've got to think. Yesterday I was putting all these pieces of the puzzle together, and it was just, it makes it worth doing, because that someone else may not give the time or the effort or the skill to it, and so that you're proud of those outcomes, and the technology's fun. I brought IPL in and allergy testing and just other things where, again, you're not flipping dials. Every day is a little bit different. Every case that comes in, a little bit new, and different pieces of the puzzle you put together, and you feel good because you're able to do it.
So, Crystal, you live in Wilmington, North Carolina, as we said. Is that near the water?
Oh, yeah.
Okay. Is it on the water?
It's right out there. I don't know if you can see it.
Okay.
But it's good.
So in that environment, is dry eye a prevalent condition?
It is. You would think not. You would think that John would get the points for this, right? No. That's all I do anymore. It's 100% of my practice, and I get referrals from all the surrounding practices because they either don't want to deal with it or haven't gotten the outcomes they want. But it's very prevalent.
Okay, that is great.
So why don't people want to deal with it?
I think because they're so used to trial and error and throwing something at it and that doesn't work. Give it back. Let me try this. Let me try this. That they get frustrated because I don't think that's the way to do it.
Mm-hmm.
I think there's another thing too in there, if I may interrupt here on this. I think that it has to do with the time element that's involved, because it does take time. It's not something that just comes naturally. There's a definite time element. A lot of people just either don't have the time or don't want to take the time. And I think the latter is the one that really is the issue. My feeling is much like what I heard Jason, you and Gary talk about when it came to myopia control. Why not do this? You're helping your patients. That's the biggest single item when it comes to this, is that the bottom line, yeah, sure, it always helps your revenue, but that's not really the reason to be getting into this. I started into this dry eye arena 30 years ago this year. And I hate to admit it, that's a long time, but there wasn't much either known or no one really cared much about dry eye back then. And we really had to sell things like plugs, of all things. If you remember, Craig, back in those days, that was the big deal. And we didn't have anything else. That was what we were trying to get across. And even that took time, and a lot of people didn't want to learn it. So it's been an evolving process. But I've heard Crystal say this a number of times too, that, and it's 100% right, is do something. These people are going to end up going somewhere else. If you don't take care of them, they're going to find somebody else that does.
Yeah, definitely.
Hey, Craig.
you know, here, yeah, go ahead,
Greg,
Jason.
did you, I'm sure this was back in your era, but did they used to make plugs out of stone? Did they chisel them out of stone?
They did. They did.
You
It was,
probably use those,
Like
didn't you?
foreign body sensation.
yeah, it was really difficult until, you know, my buddy Da Vinci worked out some of the details.
Right.
And then, you know, at that point, things got much better, easier
Right.
to handle. And you could actually put one in with one hand rather than two hands.
I read that in the history books, right? Yeah.
Yeah, excellent. Excellent. You know, I did want to comment. Of course, I live in South Bend, Indiana. I was part of an ophthalmology group for, you know, decades. And when you look back on it, the dry eye treatment that we utilized for so many years was a handful of different lubricants in artificial tears and say, here, try these. And, you know, if you find one you like, maybe buy another bottle,
But
which
Craig,
seems insane
that's
today.
still happening.
That's still
Let me
happening.
interrupt. You know, yesterday the patient comes in and she's seen 5 doctors and I'm like, okay, what have you tried? List it out here. All I have here is artificial tears. And she's like, yeah, that's all they gave me.
Yeah, that is fantastic. And so, John, in particular, going back to the question I asked Crystal, she's in a more humid environment. You're in Colorado, directly the opposite. Do you go about the treatment regimen differently, do you think, compared to what Crystal might be doing?
I think at one time we probably thought we did. We would call ourselves kind of the dry eye capital of the world, you know. Then all of a sudden I've got a place in Arizona and I realize, you know, there's a tremendous amount of dry eye there. And then, of course, the other aspect is in preparing all of the work that Crystal and I have done together. You know, here she is in a human environment and there's plenty of dry eye there. So I think it's really no different. People, though, when they come in, they will say, you know, I lived in New Orleans, for example, and I've just moved to Denver. And I really didn't have many problems there, but I seem to have them here. So whether our environment, not just the fact that we're a mile high, but the fact that we're a mile high with lots and lots of pollution at the same time, all of those things play a role. But I think the underlying problem was there to begin with. It doesn't make any difference where you are in the country.
It was internal, John, right? Because it's not just where they're living, it's what they're doing to their bodies. The device, the medications, the systemic disease, the diet, the lack of sleep, all this stuff. And also, I think the allergies, because people say the same thing of, well, I lived in Colorado and I was fine. And then I came to Wilmington. And
well,
now
that's
it's
true. You know, that's really true.
That's what gets us.
Because there's always in every environment a new set of some type of allergen there that's going to be a problem. There's no question about it. And, you know, one of my closest friends is an allergist here, and definitely we've discussed a lot of these types of things. And, you know, people, when they first come to a new environment, it's like having an allergen present for the first time. Doesn't really bother them, but when it continues to present, then all of a sudden they have those issues. And I think it just makes them more aware of the dryness that they're feeling at the same time.
Okay, that is great.
Hey, John,
Jason?
that helps. I just learned a lot because I always wondered why when I was around Craig, my eyes were so dry. But now I realize it's noise pollution. It makes perfect sense.
Pollution, diet, what he's putting in his body, all of those things.
Oh, is that now? Okay. But I wanted to blame it on Craig, but.
Okay. So Jason, do you have anything to wrap this first segment up?
You mean
besides that
valid points?
That silly comment?
No, you know, I do have a couple of comments, but I'm going to hold them off for the next point because I think we might touch on them anyway. So
okay, let's give him a point for holding it off and not boring us.
That's my best bet is to.
Okay, so let us round this up for this first segment. Crystal, 5 points. John, 4 points, right there. Could have probably given you another one, but nah. Jason, 2 points, both of which just happened in that wrap-up, by the way.
I love it. Hey, Craig, by the way, you look great today.
Bingo, there's 3.
There's 3.
Can it come back?
Okay, great. Thank you very much. They're very interesting, really quite interesting. So let's move on then. And we have a couple of different ways we can go with this, but I'd like to start with, where do contact lenses fit in with dry eye management? You're both known as contact lens people also. and experts
Am I
in
not
that
here?
area. And well, I said people.
You said both.
Both.
Don't leave John out.
Okay. Jason made it funny. First one in 4 episodes. Gets the point.
It's gonna come back.
Okay.
Come
So,
on.
John, let me start with you if I can. Are contact lenses part of the problem? Or are they, really part of the solution, or both?
I think both. They certainly can be part of the problem. And again, it's how a patient interprets it. As I said, we've had people that move from these more humid environments. No matter what type of lens they're wearing, they say they were able to wear them 15 hours a day, and all of a sudden they're down to 8 hours a day, and they're not comfortable for 8 hours. And when we start investigating the underlying issues, it's not necessarily the contact lens. It's what's in the ocular environment beside the contact lens. And even if they were to go without those lenses, they're still going to have the problem in this particular environment where they're living now. And that is a true statement all the way across the board. So as far as whether contact lenses exacerbate it, I think maybe it makes people more aware of it, but I don't think they really do exacerbate the problem. Now, having said that, if in fact you have a poorly fitted lens, that may be an entirely different situation. But the truth of the matter is that most of us, when we get patients that come in, I mean, we've got good practitioners out there fitting lenses well. That doesn't seem to be the issue, but they really overlook that dry eye aspect of things.
Mm.
Okay, that's great. So like Crystal, for instance, you have this category of dry eye, right? And then there's this category of contact lens induced dry eye, right? That just happens with the contact lens wearer that wears soft contact lenses, and it's really an issue with that. Do you handle those two situations differently from each other?
Typically no, because I think they all have an underlying dry eye element. Even if they were to stop their contact lens wear altogether, it might reduce their symptoms temporarily, but it's still stewing. They still have structural issues, even if they're asymptomatic at that point without contact lenses, that need to be addressed. And, to John's point, he said that sometimes it exacerbates the symptoms. Absolutely. But I think on the flip side of that, sometimes it delays diagnosis. Had one yesterday. She wears a monthly lens, and yet she walked in the door, not terribly symptomatic, but 0 glands. One of my top 3 most naked lids. And I think that part of the reason she didn't start hurting sooner, and she's hurting pretty bad now, but it was because of that daily covering. It was acting as a bandage lens to some effect.
Okay, that's interesting. Jason, what do you think?
Yeah, I loved this. I mean, I was taking so many notes as you guys were going through this. I totally agree. I think contact lenses don't necessarily make it worse, but chronic misuse of contacts can, and solutions and things like that. And one of the things that we'll teach at the school is everybody that walks this planet is on the dry eye continuum from 0 to 100 somewhere.
Really?
And some of us are further down the road than others. And when you put a contact lens on your eyeball, you immediately move down the scale toward more dry eye. And how far you move down that scale depends upon how good the fit is, what solutions you're using, what material you're in, et cetera, et cetera. I could put a premium daily lens on a patient and barely bump them down that discomfort road at all. Or I could put a poorly fitting lens with a bad multi-purpose solution combination for that lens and a bad fit and push them all the way into significant symptoms. So, I think my approach to dealing with dry eye patients who are contact lens wearers is the first thing I do is to make sure their contact lenses are optimized, and then reevaluate where they are on the dry eye spectrum and see what needs to happen, because I don't want to embark down a treatment plan when the contact lenses are causing a bigger part of the problem than they need to. It's just, again, it's they're not going to come out of their lenses necessarily. So let's get them as lens neutral as we can, and then really reassess the true dry eye, which is not contact lens related, and then go from there. So, but I agree that wearing contact lenses, no question, it decreases corneal sensation. It allows you to put up with dry eye maybe longer in some cases before you intervene because you're less symptomatic until it gets to the point of, and then once you do start dealing with it, I think it's a longer road back because of the contacts. So, I mean, I love contacts. I'm not down on them in any way, but I do think that being smart about how we prescribe them makes a big difference. And I think we're often too cavalier with how we prescribe soft lenses.
Yes.
I agree with you too on that, Jason. I think the other aspect is I remember back many moons ago when I was in optometry school and I had a professor that basically said anytime you put a contact lens on the eye, you're going to induce a low-grade pathology. I don't think he was referring to dry eye because dry eye wasn't really even considered to be an issue back then. But the fact of the matter is that it is an issue. And if you don't have a well-fitted lens, no matter what, you're going to be in trouble. But even with the best looking lens in every possible way, whether it's a soft lens or whether it's some form of a rigid lens, whether it's a scleral lens, it doesn't make any difference. If you have those underlying dry eye problems, you've got to get those fixed. And the practitioners that ignore that and just simply work on the contact lenses, ultimately that's going to fail.
Yeah.
Excellent, excellent.
If I can interrupt, I think that what we're all saying but haven't actually said the words is that when it comes to dry eye and contact lenses, there's a much bigger obligation on our part for the patient education part to make sure from the beginning they understand and are limiting their wear time and all those good things.
Excellent. Can I build upon what John was saying and ask you, Crystal, do scleral lenses fit in here anywhere at all for the normal, non-pathological cornea that has dry eye?
I think some patients definitely get symptomatic relief wearing the scleral lenses. Mm-hmm.
Okay, great. Jason, anything to add? By the way, Jason, I just wanted to say, when we record again, we're going to do it early in the morning like today. You're significantly smarter in the morning. It must be like a downhill ride from here.
Yeah. You're probably right.
Much wine.
By the way, John, I was going to ask you, that professor you mentioned in optometry school, was that Craig?
Good one, Jason.
So
you made me laugh twice today. It's amazing.
First times for everything. So I agree with Crystal. I think scleral lenses are for the patient who has dry eyes, who's intolerant of lenses otherwise, but wants to wear them at least occasionally. I think they are great. And so if you have a patient who's got a prescription where they want to be able to pop in contacts for social occasions or something, and they can't put in a soft lens, it's just unbearable, so sclerals are great. Now, the key thing about sclerals is they are not fixing any dry eye problem at all. They're not a cure for the disease. In fact, we call it, instead of ocular surface disease, when you're wearing a scleral, you have scleral surface disease. And it's actually probably worse than if you didn't wear the scleral, because the scleral lens is it's a piece of plastic, so that's not good for the lid wiper, and it's pushing out the ocular surface by 600 microns, and it's popping open your lids wider to have more surface drying. So in and of itself, the scleral lens is not helping the dry eye at all. It's just keeping the eyeball underneath the lens much healthier, which is very beneficial in a lot of ways. But there's no way we can say that, well, I'm going to treat this dry eye with a scleral. You're not treating the dry eye. You're making them less symptomatic. You're giving them vision correction with comfort, but you are not dealing with the dry eye necessarily, other than to heal the cornea that suffered from the dry eye.
Right.
I think, go ahead, Crystal.
Sorry, John.
No
but then they may have more partial blinks and then less oil getting into the surface. So in some ways, you might be healing the SPK and the cornea, but in the long run, putting less oil on the surface.
Yeah. I just recently had a patient a few months ago who came in and with some dry eye and scleral issues, and her lid wiper under her lid was bleeding from being so raw from rubbing on the scleral. So again, we just have to be real careful that when we manage dry eye patients with sclerals, that we educate them that this is giving them relief, it's giving them vision, but you still need to do all the dry eye therapy otherwise that you would, if not more.
Well, the key to what you just said as far as managing with a scleral, I don't think you can necessarily do that. I think the first thing you have to do is to manage the dry eye. In other words, that most of dry eye in meibomian, gland deficiency of some sort, lid problems, such as a low-grade blepharitis or even more grade than low. Those are critical issues, and we have to be able to manage that first. Then we can look at what's going on with the scleral lens at that point. But if we just try to make changes in the sclerals, redo it, do this, do an adjustment here, an adjustment there, it's still ultimately it's not going to work.
Yeah, I would just say to that end, John, that if I had a patient who came in with OSD that was severe enough that their vision was actually reduced from keratopathy, I wouldn't hesitate to get them started with sclerals even as we're dealing with the dry eye. Now, if they don't have reduced VA and their ocular surface is not at risk, I agree, I would wait and do all the other treatments first, because you may not need the scleral lens by the time you get done with all of that.
Okay. Excellent. That was a great session, really. And I want to just recap the scores, if I could. Crystal, you have 8 points. You were leading. Maybe there's a chance for a comeback in our final segment. John has 10.
Whoop, whoop.
John is hanging in there, and he's really on top of his game today. And
early out there. It's even earlier there than it is here.
And Jason, for the first time ever going into the final round, is leading with 11.
Wow.
Because I'm funny today, Craig.
I don't know if it's
you, at least.
You're funny or because our contestants are a little weak today.
That's what I was worried about.
Hey,
what
guys,
do you want from us, Craig?
I want to officially apologize for Craig.
It's not the first time he's had to actually do that.
True.
Okay, before we go into our last segment, I'd like to ask our guests in particular about instrumentation and stuff in the office and where, in a couple of brief words, the OCULUS instruments might take place. And Crystal, I'd like to start with you. I noticed that you utilize the dry eye package relative to the keratograph and the Jenna report. Can you talk a little bit about how that works?
It's the cornerstone of my practice. I cannot imagine doing what I do without the 5M. And I use it, just on a side note, within my 3 minutes, one thing I advise all people starting out is to screen every patient. And they have a beautiful screener on there that lets me do tear meniscus height and either interferometry or non-invasive breakup time and redness. And then the patient gets a nice report, and it's great for conversion into a dry eye eval for those patients who might not be as symptomatic. But when they come back for the dry eye eval, I'm able to collect all the data and go through my categories to explain to them what's wrong. But the most useful thing is putting that 9-picture collage up there. And I can say, we're a little bit low on water. Look at the lid margin. See how those glands are puckered up. That oil's not getting out. There's no color in this tear film. The tears are evaporating quickly. Here's the long-term damage to the glands. Here's the toxicity in the tear film and the inflammation and redness it's causing. And all of a sudden it makes sense to them, whatever it is I'm asking them to do, because there's a reason behind it. And that creates the compliance, and then the compliance creates the outcomes. So without it, I feel like there's no way I could get the outcomes that I get, because that understanding and that motivation wouldn't be there. And then when they come back to me, I can look at that and say, oh my gosh, look at this color. This is beautiful. And I get them excited. And I mean, just yesterday, I had somebody say, for the first time, I've got hope. It was a 5M, and me explaining what we were seeing there that gave her the hope.
That is an excellent tip. And, especially with the ability to not just show them something, but it can be a takeaway at the same time for them. John, do you have anything to add to that at all?
Well, I totally agree with Crystal. I think that the OCULUS 5M is invaluable. And any time that we're lecturing on this and talking to our colleagues, we need to let them know that if they really are going to embrace a dry eye treatment, they need to also embrace dry eye diagnosis. And the best way to do that is with the OCULUS 5M. There's nothing in the market or on the market that it even comes close to what you can do with it. And it's not a commercial, it's absolutely a truism.
Mm-hmm. And on top of that, as far as building referrals, I send that report back. So I use the Crystal Tier report instead of the INVIS, slightly biased, but only a little bit. But it has the pie graph that tells them how they're doing. It tells them what test we did, what their score was, the definition of the test, and then the treatment specific to that category. So we hand that to the patient, but we send it back to the referring doctor. And what that's done is it validated their referral. So constantly I've got patients in the chair who say, my doctor referred me to you because you have the equipment for this. And it's verbatim. They say it over and over. And it's that 5M that kind of established that in building validity to what I do.
Okay, that's fantastic. Obviously,
I get a point for it? I mean, come on, Craig. You're dormant on the dings.
Okay, you convinced me. See, it's the begging that works.
Oh, good.
Apparently so.
Yeah, apparently so, exactly. Okay. So
I think John did a good job too. He should get a point.
Sure, why not?
Hey, do I get to say anything to get a point?
And frankly,
You're
how
in the
about
lead.
this? Stay quiet for 30 seconds. Boom, you get a point. Okay. So let's move on to the last segment. And this segment is the fun segment. So we got past the eye care part of this. And what we'd like to do is to just ask you that, of course, you guys have had the opportunity because of your lecture skills and your expertise. And Jason, I'm counting you in this now also, to be able to travel not only across North America, but across the rest of the world. So Crystal, I'd like to start with you and just ask you, what is your favorite place you've ever traveled to that was related to lecturing? And then we'll ask John the same thing, and then we'll ask if it was ever together.
Well, I got to credit John for this one. I think my favorite trip was last year in June on Sea Vision. And so we were together on a boat, and he can tell you every little destination much better than I can. And so I'm going to dumb it down. The boot, we started at the top, up at the knee sock, and then we went all the way around to the other side. So we started in Venice, ended up in Barcelona, but it was the Amalfi Coast, and it was Tuscany, and where else? Croatia, and oh my gosh, it was beautiful. Even in bad weather, it was beautiful. That was my favorite. I love Italy.
It's a hard gig to match.
It is. It is.
He can match it though. He was there, but it may not be his favorite because he's been on more places.
Yeah. John, what about you?
Well, I think I have two. That one definitely was a favorite, no question. In fact, it was the second time that we had repeated that Sea Vision simply because it was such a great venue. And there's no question about it. I mean, Italy is fantastic. And I think the way we did this in terms of our education, we always had that on board the ship, and then free time for everybody, once they were somewhere else. And so we did a lot of this together. It was a really great time. The second one was just this last year, prior to all of this COVID-19 stuff, was in South Africa. We went on a safari, and we did some cruising there, which wasn't all that wonderful, but the safari was absolutely primo in every possible way. And again, combined it with education. So our philosophy was, when we started Sea Vision, which was 25 years ago, that we wanted to have a venue where we could have a lot of fun, but still get some education in the process, and be able to obviously write off whatever we were doing. If the IRS was listening, that's what we did. So it was really a great thing. We had wonderful speakers, very much like we had Crystal several times on there, and it was just, these have been great events.
I thought it was always about the golf.
This time, no. In fact, I don't ever, well, I shouldn't say that. One time I remember in the Bahamas, I think, playing golf, or maybe it was Bermuda, I don't remember, but one of those. But otherwise, no. No, golf had really nothing to do with any of this.
Yeah, that's wonderful.
Now,
Jason?
you mentioned that the CE started at like 5:36 in the morning. So it wasn't so bad because everybody was asleep, and it's kind of like just a rehearsal sometimes.
Yeah. That is great.
But I got to say, as far as the states, Dry Eye Institute, it starts today and tomorrow. We're doing our weekend retreat, and it's Wilmington. Not many better places in the States.
Yeah, interesting. Jason, what about you? Do you have a favorite?
Yeah, I do actually, and it's same as John's. 3 years ago, I guess, spent 10 days in South Africa. Not only was the thanks to the Contact Lens Society of South Africa, the conference was great. We got a tour of Johannesburg, Pretoria. We had 3 days at a golf resort where they had reserved the entire resort with all the villas, and we had beer tasting, gin tasting, live music at night, and we had then we went on safari for 4 days to a private lodge. It wasn't just that it was a great experience, it was just that the people there were as great, friendly, accommodating as any people I've ever met in the world. So
well, I agree with that, Jason.
Yeah,
absolutely agree with that.
Just the best hosts and hostesses you could ever want. So if you ever get a chance to go to South Africa for a conference, I highly recommend it.
That's fantastic. And for any of our viewers that are young and trying to get their career started and want to lecture, we would strongly advise find an area of expertise, become really good at it, and you too might be able to see the world.
That's right.
Because there are conferences everywhere today, and as soon as we get by this stay-at-home crap, that it will, open up once again, and truly you get a chance to see the world and see so many things you couldn't do in any other situation.
Mm-hmm.
So we're going to wrap this up right now, and to
Hang on
do
a
that.
second. All I want to know is, I want to know when I get to go on a cruise, John. So I'll be watching my inbox in the next.
All right, no problem.
He gets a point for pleading.
Yes.
He's good at that,
It's not manly. But
if I can't make any valid points, I have to try to get points other ways.
Yeah. Excellent. So I'd like to wrap this up at this point. And Crystal, do you have any comments to make in closing relative to today's discussion on dry eye and managing in the practice? And
all I would say is I've found what has been the most rewarding. I feel like I'm able to give a service that I was never able to really give before, and fill this need for patients who are just miserable. And multiple times throughout the day, I'm just thankful for what I do. And I don't know that I felt that before. I kept getting bogged down by the burdens of running the practice. And now it just feels so much more in balance because I see changes in them and their quality of life because of being able to treat dry eye well. So I encourage you, go in all the way. The people will come and you'll never regret it.
Yeah, that's really insightful. John?
Yeah, and Crystal's right. If you're going to do this, do it right. There's no question about it. It's important. If you don't, you need to refer to somebody that does take care of dry eye patients. They are the most grateful patients in the world because they've lived with many of these issues for decades. And they've talked to many doctors about it. Most of them do that little brown bag approach where they start throwing all kinds of drops and gels into the bag and say, here, try it and see what works. And that doesn't work at all. The only thing that I would say with the technology that we have today, which is so far superior to what we started out with, which was almost nothing, that there's no excuse for not taking care of these patients and not doing a good job. The one thing that I would say when we go back to things like the slit lamp, as we start looking at our diagnostic routine, make certain, absolutely certain that you look at the lids first when you start to look at the patient, because so much of it is identified right there. And that is a big deal. It really is. No matter what your routine is, no matter whether you go in this all the way or just part of the way and you have certain tests that you do, just make sure that that's one of the things that you include there. And then have a routine that you can not only do on a regular basis, but modify if you find that it isn't doing the job that you need it to do.
Excellent. Excellent, John. Thank you very much. And you needed that point, by the way, at the end with that last tip.
Oh, I did.
Jason.
Okay, otherwise I would have had to beg.
I would just say the real, we talked about the treatments, and the treatments for dry eye are growing, the options, that's all good. But if you're really not doing dry eye and you want to, before you invest in a lot of treatments, you probably need to invest in the diagnosis part of it.
Absolutely.
You have to get the right diagnosis first before you can even think about the treatment. And moving from this whole business of dry eye being this subjective complaint or subjective diagnosis, you need to move as far to the objective as you can, because as everybody's already said, it allows you to show patients when they're improving, even if they don't feel it. And a lot of times that's the case, right? It takes sometimes a long time to undo these things, so the symptoms don't go away overnight. And as you can show them improvement without necessarily them feeling it, they trust you and they'll comply. So moving towards the diagnostic and the objective is the key to making this work. So.
And Jason, if you're going to get serious about this, really, I'm going to put in a plug for Crystal's Dry Eye Institute, because I know what she's doing there, and anybody that's attended it has just raved about it. And I'm certain that would be the case for anybody.
Thanks, John.
Okay, well said, John. Well said. Okay, I want to first of all wrap this up and show you the final scores. Jason, close, no cigar. 14 for Crystal. Pretty good.
Very good.
14 for John.
Oh,
At last minute, and plus he gave that little plug to Crystal. She won't mind that there's a tie now. Jason, 12.
I'm proud.
Well, I am too. I'm actually quite proud of you. Also, you're showing some growth.
Yeah.
And with given a little time, maybe you'll get into second place.
Well, it was a strong topic for me today. I could actually contribute. So
yeah, actually, guys, it was a fabulous topic area today. This was really quite educational. I think there's a lot of tips for everybody that was or is going to watch this. And to learn about dry eye management, this underlying disease process. I thought paying attention to that. Jason, I didn't give you any points, but your comment at the end about making it objective, I think is right on the money also. Didn't want to give you the points. It might go to your head. You might get a little closer to all that stuff. But
Can I say something about that? Because I was going to mad at myself if I didn't throw this in there. So Jason, you said make it objective. I harp on that all the time. Think about the screening. I never use surveys. And the reason is when that patient comes in, I don't want them to think that the things I recommended or saw was based on their feelings, because then they'll say, it's okay. Or they feel better and they stop. But when I use that 5M screening report, it's exactly what you said. It's making it objective. It's about the structure, not your symptoms.
And that made her the winner.
Wow.
Oh, nicely done. Well played, Crystal. Really well played. That wrapped everything up perfectly.
I love it.
So I want to thank all three of you for today. Again, as I said, it was really fantastic. I want to thank Oculus for their ongoing support for May I Interrupt. These episodes are shown on YouTube, on the Oculus YouTube channel. It's also available as a podcast form off of iTunes or wherever else you download your podcasts. Thank you guys very, very much for the opportunity to be involved with this today. I'm really the winner here. I get to spend a little time with the experts. So thank you very much. And John, at this point, you can start worrying about exactly making that tea time.
Absolutely. I'll make it. No problem at all. And Craig, it's been a pleasure. Thanks very
You
much.
bet. John, Crystal, Jason, thanks everybody.
Thank you, Jason. Thank you, Craig. Love you, John. Wouldn't rather be here with anybody else. Thank you.
I agree, Crystal.